Thank you for this opportunity, and it's great to see such a full room and interested audience. So I'm just going to quickly run through the trials that we're running through ANZUP currently. So just to give a bit of background, and probably most of you know this already, that urological or genitourinary cancers, they make up about a fifth of cancers altogether. So these are common cancers, and the numbers up there will give you a rough idea of how common they are. Prostate cancer is the commonest cancer that we treat, and certainly probably in the media and amongst people that you know, you might hear a bit more about prostate cancer than most other cancers. Bladder cancer is also, relatively speaking, common. The remaining cancers we treat, kidney cancer, testis cancer, penile cancer, there are one or two rarer ones that I haven't even put up on the list there, become progressively less common. So some of these don't have that big a profile, but certainly prostate cancer is well known out there. And most importantly, these are common cancers that cause lots of suffering and death, and they need good treatment. They need better treatments as we go along, and that's really what we're here for and what we're about. So just a little bit of background about the general principles about treating cancers. People use the word cancer, and cancers are not all the same, and they're different because of where they come from. So prostate cancer is different from lung cancer, which is different from breast cancer, etc. But more importantly, even within one particular type of cancer, there are what we call early or localized cancers, which are often very treatable and curable, and there are more advanced cancers or metastatic cancers that might be a greater threat, and those are the ones that are sometimes potentially lethal and potentially a greater issue. How do we measure that? There are a few parameters that you'll hear as we talk about cancers, whether it be in the context of studies or in the context of treating a particular patient. There is this concept of grade, which tells us about how aggressive a cancer is. It really measures how close to normal looking the tissues are. Is it looking like prostate, or is it looking more like abnormal tissues? And the more abnormal tissues are, understandably, that usually means that more aggressive the cancer is. But in addition to the aggressiveness of it, cancer is also measured in terms of the extent of it, and that's called stage. And that tells us, is it just contained within the prostate? Has it gone just beyond the prostate? Has it gone to other parts of the body? And again, understandably, the more extensive the stage is, the worse the situation is, because we've got more to treat for starters, and it's often difficult to treat cancers when they're very extensive. It's much easier to cut out one bit or radiate one bit. It's much harder to do it on a broader scale. So the summary down the bottom there is the lower the stage and the grade, the better. So the earlier we can pick it up, the better it is. So how do we go about treating cancers? I'm a surgeon, so we do surgery, and there's radiation, which our radiation colleagues undertake. And most often this is done for what I said before, are early or localized cancers, because we can target it to one particular part of the body. We can remove a prostate, radiation might be given to the bladder, etc. Chemotherapy is often the treatment that people think about when thinking about cancer treatment. It's not used in every cancer, but it is most usually used when it's sort of spread more widely in metastatic cancer. But in fact, chemotherapy is often an adjunct to when we're doing surgery or radiation, and it can help make those treatments better and make the effectiveness better. Certain cancers are susceptible to hormonal influences, so we do treatments that are hormonal therapies, blocking hormones or giving specific hormones. And for our cancers, prostate cancer is the classic one that we do use hormonal therapy for. Immunotherapy is something that is very much in the news these days, and there's an increasing number of these immune drugs. They have specific roles in altering the immune system's responses to cancers, and they have specific roles in certain cancers. Again, for our cancers, bladder and kidney cancers are the ones where immune drugs are finding a bit of a space. I've mentioned some of the conventional treatments, but not to lose sight of the fact that in addition to all the things that I've listed in there, there are other treatments that are important every day in terms of managing cancers, and that includes things like pain management at an advanced stage. It includes things like physiotherapy or diet or exercise and supportive care. This is a very stressful time. There are lots of impact both from the disease as well as from the treatments that we end up giving people. So what do we need clinical trials for? We seem to have a fair armamentarium of things. The problem is we're not at a perfect stage. Cancer still causes suffering, cancer still causes death, so we need to improve what we're doing. And we continually want to improve that, and the only way we can do that properly is by testing things out in clinical trials. And the sorts of interventions, sometimes it's new treatments, a new drug, a new operation, but quite often it's new combinations or new ways of doing things, or doing it in people that we didn't used to do it before. And all of that needs testing, because it's fine to imagine that this is going to work better, but we need the proof and we need the evidence to show that. And how do we measure that? We measure that by means of what are called endpoints, and the most common endpoint is survival, and that means how long people are living for. There may be kind of subtle variations in survival. We might measure how long people live without cancer, for example, but in the end it's all about improving that, extending life. But there is another aspect to this. It's not just making people live longer, but whatever length of life is there to make that better, and that's what quality of life measures. So we're trying to see that there's a better life or a better period of survival that we have. So to move on to talking a bit about some of the specific trials that we're involved with, I'll run through these fairly quickly, just giving a brief overview of the trials. There are various trials that are currently open to recruitment. In other words, there are patients being looked for and where they fit are being enrolled into the trials. The majority of trials I'll talk about are in this category. There are certainly some trials that have finished and are being followed up, and then there's a bunch of trials that obviously are being worked upon. That's the list that we currently have, and the black ones are ANZUP trials that are currently recruiting. The red ones are ones that have been completed. The blue ones are not ANZUP trials per se, but they are collaborations that we are helping to promote. To run through them fairly quickly, and this gets to be confusing as I rush through things, but at the top here I've got what particular condition or cancer we're targeting and what stage of cancer we're treating. So the first one I'm going to talk about is called the Accelerated BEP trial, and in brief summary this is looking at a different way of doing chemotherapy, giving the chemotherapy quicker or more frequently if you like, looking to see whether that improves outcomes or not. It's been going now for about 5 years. It's planned to be, it's an ambitious study, big study. We're really in the first stage at the moment, and we've recruited 90 out of 150 patients. The next trial I'm going to talk about is the Pain-Free Trust B study. Again, this is a fairly ambitious trial looking to recruit more than 400 patients. This is in prostate cancer, and it's in the stage when we're diagnosing the cancer, and it's looking to see whether the process of diagnosing prostate cancer, which usually involves a biopsy, a painful biopsy, can be made better by certain treatments, whether we often use local anaesthetic, whether adding in this methoxyflurane, which is the little green whistle that ambulance drivers carry around and give to people in pain, whether that can actually reduce the pain or not. We've almost completed the enrolment for this, a few more patients to go on. The next study is a bladder cancer study, and this is localized bladder cancer. These are patients who are typically having treatment that is given into the bladder, and BCG, I've got some abbreviations there. BCG is the TB vaccine, and interestingly, that seems to work against bladder cancer, and it's a standard treatment for this type of bladder cancer. It works well, but doesn't work in everyone, so we're trying to improve the treatment, and there is some evidence to say that if we add in the chemotherapy drug mitomycin, that might make it a better way to treat it. So it's comparing the standard treatment to the BCG alternating with mitomycin. Again, this is a two-stage study. We're now into the second stage. I'm sorry, that's actually out of date. We now actually have funding for the second stage, and 230 patients have been recruited now. Another bladder cancer study is called the PCR-MIB study, and this is one where bladder cancer is being treated with radiation treatment, again a standard treatment for bladder cancer, and it's often used, as I said, in combination with chemotherapy. So that is standard treatment, and this is one of the new immuno-oncology drugs called pembrolizumab. Difficult name, but that's an immuno-oncology drug, and we're looking to see whether adding that makes it a better way of treating bladder cancer or not. Again, this trial has about halfway recruited, 30 patients planned. You can see it's a very different scale of study because this is a very early stage study. We're just looking to introduce this into this treatment mix and see if it improves outcome or not. Therapy, I think you'll hear a little bit more about this later on this afternoon, is a category of treatment that utilises a sort of complicated sounding name there. That is actually a radioactive substance that goes around the body and gets deposited to certain areas that might have the cancer. And this is called theranostics. And I won't try to steal the thunder of the speaker coming up later on, who will talk to you a little bit about these sort of trials. But in essence, this is prostate cancer that is at a very late stage. It has had multiple treatments, and that other treatments have failed, and the cancer is growing. And we're looking to see whether a standard treatment, which is this chemotherapy drug, cabazitaxel, when it's compared to these new drugs, how patients do. This is a study that was looking to recruit 200 patients, and it's sitting at 187, so it's fairly quickly going to recruit the remaining patients. A few kidney cancer studies. These are all metastatic kidney cancer studies. This is looking to, again, use some immuno-oncology agents and looking to see how, like I said, sometimes we're looking to see how we combine or sequence these drugs, and that might be the process that we're studying as it is in this particular case. Again, this is a study looking to recruit 85 patients, and we're almost recruited. The next one is, again, an immuno-oncology drug plus another drug that works on the bone where the cancer can spread, and again looking to treat patients with kidney cancer that has spread to bones and see whether this combination can help those in whom they've had a previous treatment. This is looking for 70 patients, and about 30 or so have been recruited now. And the third study, again in metastatic kidney cancer, is looking at a similar combination but in non-clear cell cancer. It's only just opened. The final one here is the TIGER study. This is in metastatic germ cell cancer, and this is looking at 2 different styles of chemotherapy to see which one actually has improved outcomes. And again, this is relatively recently opened. This is a rare condition, as I showed at the very outset, and we've recruited a few, but obviously looking for more patients there. A couple of the closed studies, the ANZUP trial, some of you may have seen some mention of this in the media. This is a study that has fully recruited. Enzalutamide, which is where the trial gets its name from, is one of the new hormonal agents. It's being used in various different settings, and this was one of the trials that was looking at using it relatively early on in the space, at the time of new diagnosis of metastatic prostate cancer. Very big study, and ANZUP really led the study across the world with patients contributed from Europe and North America, and the results were presented at the recent conference in June in the US and showed a very dramatic improvement in survival, about a 1/3 improvement in survival compared to conventional treatment. And not surprisingly, it generated a fair amount of media coverage, as sort of summarised in that slide. And
a simple pill could offer men with advanced prostate cancer a longer life. An Australian-led study has found the treatment improves survival rates by 30%.
After receiving the bad news his prostate cancer had spread to the lymph nodes, 68-year-old Owen Reid was delivered some hope. He was prescribed enzalutamide, which works by blocking the effect of testosterone on prostate cancer cells.
Fortunately, I was put on the trial early enough, and I think I'm reaping the benefits of that now.
Overnight, the findings of that trial, led by the Australian and New Zealand Urogenital and Prostate Cancer Trials Group, were presented in Chicago. 1,125 men took part in the study. After 3 years, 80% of men who received enzalutamide and hormone treatment were alive, compared to 72% who'd received standard treatments.
Even after a short period of follow-up, there was a 30% improvement in the survival of people treated with this drug early on.
Here in Australia, prostate cancer is the most commonly diagnosed cancer in men, claiming about 3,500 lives each year. That's more than breast cancer. Enzalutamide is already available here, but only to patients who are no longer responding to hormone therapy and chemotherapy. The authors of this study say their research provides a strong case to give the drug earlier in the disease process.
There's more and more accumulating evidence that our best drugs are probably best used early in the piece.
At this stage, I'll live forever. So.
Kate Creedon, 9 News.
Well, we really hope our patients do live forever. Another similar study, which has completed but has not yet reported, was looking at the use of enzalutamide, but in a slightly different group of patients. These are localised prostate cancer patients who are having treatment with radiation treatment in conjunction with hormonal treatment. So this again recruited 800 patients, and doing these really big studies across multiple countries is a huge exercise that ANZUP should justifiably be proud of. There's a very quick list, and I don't intend to go through the detail of all of these studies. These are all the ones that are being considered, and it ranges from kidney cancer trials to further prostate cancer studies, to studies in cancers of the kidney that are similar to bladder cancer, etc. And so there will no doubt be numbers of these studies that are actually going to move forward from the planning stages, which is what this slide outlines, to implementation and ultimately, hopefully, reporting equally good results. Not every study is going to give good results. Some studies will show that there isn't a big difference or the existing treatment is the best we've got, but we keep doing the studies, we will find better treatments as we go along. So just to finish off, if you are interested in ANZUP, and obviously all of you are here because you are, up there is the details of how you can find out more about ANZUP. The ANZUP website's obviously a good starting point. You can join Friends of ANZUP and you will get up-to-date information. There is a consumer magazine which we put out. There are the latest issues out there for you to pick up, and they'll be sent out to you if you're a friend of ANZUP. Particularly, I think, for your doctors to access and find out what studies are running, and to make sure that you're able to find out and come to access ANZUP trials. There is actually an app that lists currently active ANZUP trials. So just to finish off, what should you do? I think everyone needs to be health aware, and so make sure you talk to your doctors, have the appropriate checkups. There are certain things for which there are designated and prescribed ways of checking people at certain ages or at certain risk factors. Talk to others. Awareness helps, and I think the worst thing about health problems is when there is a lack of awareness, and when we're dealing particularly with problems with male health. Men's health is a difficult problem, and we deal with prostate cancer and testicular cancer, both of which are male health problems. Men have a tendency to pretend that we are Superman and nothing's going to happen to us. So the more we talk about this, the more the awareness comes up and the more these things get found out and dealt with in an appropriate kind of way. And the final thing to say is that if you're a patient or you're talking to a patient, a family member or a friend or anyone, it's always important to ask, okay, well, what's the standard treatment? Is this a space where there is a clinical trial? Because it's only by you getting involved in clinical trials or your family members and friends getting involved in clinical trials that we can improve the outcomes for cancer. Thank you.